Hello everyone, today we discuss about city contrast media, its basics, its application and city contrast reaction and management. Let's start. Iodinated contrast media is used for CT scan. Modern city contrast agents are predominantly non-ionic. Non-ionic contrast produces fewer adverse reactions than ionic contrast. Low osmolar contrast media or LOCM is current standard. Isoosmolar contrast media or IOCM has osmolarity similar to plasma. Iodixanol is an isoosmolar contrast agent. Iodixanol is an example of isoosmolar contrast agent. Iohexol is non-ionic low osmolar contrast agent. Iopamidol is non-ionic low osmolar contrast agent. Iovarsol is non-ionic low osmolar contrast agent. Contrast concentration is measured in mg iodine per ml. Injection method or injection protocol. Typical injection rate for CT angiography is 4 to 6 ml per second. Saline flash reduces contrast wastage. Power injector ensure uniform injection and 18 to 20 gauge cannula is preferred for CT angio. Hand injection is suitable for slow enhancement studies. Bolus taking improves arterial phase timing. Test bolus technique estimates circulation time. Contrast volume depends on body weight. Contrast dose is approximately 1 to 2 ml per kg. Injection pressure depends on cannula size. Now we discuss about contrast reactions. Most contrast reactions occur within 20 minutes. Allergic-like reactions are unpredictable. Physiologic reactions are dose-related. Warm sensation is a normal physiologic effect. Metallic taste is a common transient effect. Nausea is a mild reaction. Vomiting is a moderate reaction if persistent. Urticaria is the most common allergic-like reaction. Angioedema may obstruct the airway. Bronchospasm causes wheezing and dyspnea. Severe reactions. Hypotension may indicate anaphylaxis. Laryngeal edema is life-threatening. Cardiac arrest is a severe rare reaction. Pulmonary edema requires immediate oxygen support. Seizures may occur rarely. Vasovagal reaction present with bradycardia. Tachycardia is common in anaphylaxis. Severe reaction occur in less than 0.05% of non-ionic contrast agent. Previous contrast reaction is the strongest risk factor. Asthma increases the risk of severe reaction. Risk factors. Shellfish allergy alone is not a contraindication. Food allergy slightly increases reaction risk. Metformin does not increase allergic reaction. Renal impairment increases CIN risk or contrast-induced nephropathy risk. Dehydration increases nephrotoxicity. Diabetes is a risk factor for kidney injury. Multiple myeloma requires hydration. Elderly patients require renal assessment. Pregnancy requires careful justification. Hyperthyroidism may worsen after iodinated contrast media. This point should be remembered. Hyperthyroidism may worsen after iodinated contrast. Contrast-induced kidney injury. EGFR should be assessed before contrast in all risk patients. EGFR below 30 ml per minute requires special consideration. Hydration is the best preventive measures. Normal saline is preferred for hydration. N-acetylcysteine is no longer routinely recommended. Contrast-induced AKI usually peaks at 48 to 70 hours, 72 hours. Serum creatinine rise after renal injury. Dialysis immediately after contrast is not routinely recommended. Dialysis immediately after contrast is not routinely recommended. Lowest effective contrast dose should be used. Repeat contrast should be minimized in renal impairment. Extravasation. This point is very important for CT contrast reactions. Extravasation is a leakage of contrast outside the vein. Swelling is the earliest sign. Pain suggests tissue injury. Stop injection immediately if extravasation occur. Elevate the affected limb. Apply cold compress for comfort. Large volume extravasation requires surgical evaluation. Compartment syndrome is a rare complication. Power injector have extravasation risk. Good IV access reduces extravasation. Emergency drugs. Adrenaline is the first line drug for anaphylaxis. IM or intramuscular adrenaline dose is 0.3 to 0.5 mg, 1:1000 in adult. Oxygen should be given immediately in severe reaction. Normal saline treats hypotension. Hydrocortisone is a second line medication. Chlorpheniramine treats urticaria. Salbutamol relieves bronchospasm. Atropine treats severe bradycardia. Glucagon may help beta blocker treated patients. Nebulized adrenaline may help upper airway edema. Now we discuss about emergency management. ABC assessment comes first. ABC means airway, breathing and circulation. Call the emergency team immediately. Maintain airway patency. Monitor blood pressure continuously. Monitor oxygen saturation. ECG monitoring is essential in severe reaction. CPR should follow current ACLS guidelines. Observe mild reaction for progression. Document every contrast reaction. Future contrast studies require precaution. Now we discuss some important fact about CT contrast. Non-ionic contrast has lower osmolarity than ionic contrast. Severe reaction can occur without previous exposure. Pre-medication does not eliminate reaction risk completely. Contrast allergy and iodine allergy are not synonymous. Saline chaser improve contrast enhancement. Contrast warming decreases viscosity. Higher iodine delivery rate improves CT angio quality. For CT angio, we used little higher iodine contrast. Renal function assessment is mandatory in high-risk patient. Every CT suite must have an emergency crash cart containing emergency medication. Early recognition and prompt adrenaline administration save lives in severe contrast reactions.